I request you guys be a little silent so you can still whisper to your neighbor, and we allow the online team to also enjoy the presence. Great. Hello. Are we together? Left hand up. Okay. Thank you. So 8:30 on the dot. If your friend, neighbor is 1, 2, mic check. 1, 2, 1, 2. One, two, check. 1, 2. 1, 2, mic check. Let's get our friends and neighbors in so that we start on the right foot. Thank you.
They're going to play a bit.
Sorry, we just have a set of keys here, mini keys that was left outside. Anybody? A set of mini keys, is that yours?
Children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe in me, rise on your feet and let's sing together. Go. Protection and nutrition. God is Thank you. Thank you, Sam. Thank you very much. A huge welcome to you all to the PATA 2024 Summit, Together in Care, Healthcare Champions for Children who are ready to end AIDS by 2030. My name is Pat Koyaro, and I'll be your chair for this session. I'm a long-serving board member of and friend of PATA. I work in Kenya for an organization called LVCT Health, heading a USAID-funded program at the coast. It's a great privilege after many years of not meet in person like this. But it's wonderful once again to welcome all of you to South Africa and being all together, doing it right and being united in care. Can you tell your neighbor, do it right? Do it together. Do it now. Great. Before we start our proceedings, we formally want to acknowledge South Africa as our host country. South Africa, thank you. I'd like us to rise for the African Union Anthem. African Union anthem, Together as One, right? Let's rise and our sound team will help us to play this. Great, thank you very much. You can have your seats. So as part of the opening session, I want to remind us all on why we are here and to reflect on the aims of the PATA Summit. One is that we need to position frontline health providers as key partners and champions in ending AIDS in caregivers, children, and adolescents by 2030. If you can do it earlier, the better. Support healthcare providers to be champions and advocates for change as they close gaps in HIV services and care. We need to share updated guidance, tools, and best practices at the summit and through our PATA Hub. We need to strengthen our network, collaborative teams, and partnerships. And lastly, promote a culture of care, exchange, linking, and learning. It's important for us to take note of those objectives that will guide us in the next 3 days. To do a quick introduction to our distinguished speakers of this first session, and I'll let all of you to please go to the hub, PATA Hub, and the summit page where you can get the full bio. And so I will just speak briefly about each of them. First of all, we have Luan Atan, who is the director at PATA. And she will provide a quick program overview and update. Luan has been at PATA for over a decade. She has held leadership roles in several national and regional organizations. And she's a well-seasoned program manager, capacity builder, rights defender, health provider, civil society advocate, just to mention a few. Please join me to welcome Luan to come and speak to us.
Morning, everyone. It's really wonderful being here. I can't quite actually believe we've arrived and we're all here together. It comes after quite a few weeks of hard work from a wonderful Pata team. So if you can just give them all a big round of applause. I'm sure some of you will remember our last in-person summit was actually in 2019, just before COVID. And since then, actually, every year the summits have been online through an online program with many of you meeting in your country hubs. So this is actually the first time we've all come back together. And this time we're trying at making sure then everybody else connects with us virtually and remotely. As you'll see in the program this year, everything is very focused around the Global Alliance to End AIDS, and that's why we're very privileged to have Shafiq, Dr. Shafiq Essegyi with us. But you'll see the whole program throughout the 3 days is really focused on the 4 pillars of the Global Alliance. So everything is aligned and organized around that. You'll see even in the marketplace, they're posters showing the different country plans on the Global Alliance. So hopefully when you all meet, there's going to be no one that isn't fully versed on the Global Alliance ambitions to end AIDS for children by 2030. I just want to talk a little bit of the structure every day, just so that you're a little clear in how to follow the program. I don't think it's going to be too complicated. But every day we'll start with daily registrations, as we have some people still coming every day. And then at 8:30 sharp, we'll be here every morning for a prime session. And then that is followed by tea and then the Africa cafes. We have 2 hours of Africa cafes. And the Africa cafes are organized every day. There will be the same Africa cafes. So there's pillar 1, pillar 2, pillar 3, pillar 4. So every day will be the same pillars, but you choose out of all of those 4 pillars, which pillar you would like to attend on which day. So obviously, try and get as much variety as possible. Unfortunately, you're only going to be able to go to 3. The 4th one, though, will also be online. So you'll be able to catch up with that one as well. For anyone who's French and Portuguese speaking, the sessions in this room will change. So the Africa Cafe, for example, in this room will change every day. But if you're French or Portuguese speaking and you need translation, you will always stay in this room because this is the only room that there'll be ongoing translation throughout the day. Okay? So the program will move in a way that everything that everyone else gets will always happen in this room, but with translation. Okay. And then after Africa Cafes, we have workshops. And then in the afternoon, late afternoon, we all registered, there will be an open marketplace. And that's just around sharing tools, exchanging ideas and experiences. So we can move on a little bit. We could move the slides. Thank you. Just the themes of the day. I mean, as I've said, those are really linked across the different pillars. The focus is all about promoting exchange. So please know it's only really the prime sessions that are going to be quite formal. But all the Africa cafes, the workshops, there's a lot of time in terms of discussion and exchange. That's what we want the focus of the 3 days to be. Our workshops will change every day. But what you can know is that the same workshop in this room today will be the same workshop in another room. Okay? So you're getting the exact same workshop. It's just that we wanted the numbers in the workshops to be a bit smaller so that we can have discussion and exchange. So please just keep track in your program. You'll see today is really all about champions and health providers as advocates. You'll see my T-shirt that comes from Cameroon because it's all about healthcare providers being at the forefront. And that's the celebration of today. and throughout the whole summit. Tomorrow is a little bit more focused on service delivery, comprehensive care, and on day 3, a little bit more on structural barriers with a focus on our face of care work, with a real reminder that all of these things we talk about in the Global Alliance, across the pillars, all these interventions, none of that would be possible without all of you. So just the importance, and we ask the policymakers and our ministries of health in the room to make sure that within their plans, there's always a focus on frontline providers, that they have the tools, they have the support, and they have the means to be able to deliver the services that we need them to. If we could go to the next slide. Just a little on who's here, all of you. What's amazing, I think we have over 150 frontline providers with us, over 20 National Ministry of Health representatives. We've had over, I think, nearly 2,000 registrations just for the summit. All of you who registered on the Pata Hub, you will know, I think we've just exceeded 7,000 members on the hub. So all of those people right now are able to access and are connected to our live stream. So amazing for that. And just within this room, with all the health facilities and all of you and the do, you need to know that you're reaching 180,000 children. 180,000 children are in treatment just through the people in this room. Amazing. Next slide, please. Okay, now the fun bits, because that was all a bit serious. So as you know, Pata summits are also really fun. They're not, we work very hard here, but we also do have lots of fun. So this evening, there will be a gala dinner and some very serious, like Pata Grammy Awards, that you still have potential to get into the front running seat for some of them. But please just join in on all the challenges we have. There's lots of social media using the hashtag Pata24 Summit. There's also something in the hub where you can change your frame and put yourself in it as a health provider champion. So please do that. And we also have something which I only learned about yesterday, which is called a thunderclap. So we're asking, as you all leave the prime session and you go to tea, so we try and do it at the same time every day. And please use those hashtags for the thunderclap and just share anything about what you hope to learn, what you're looking forward to, anything like that. So please support that. This evening at 7 is the gala dinner. I'm sure this room is going to be looking a little different with a red carpet and all. So please put on your best traditional wear or anything else that you're looking forward to. Obviously, there's dinner and drinks. There's also any extras. If you have a bank card, sadly, this hotel only operates with bank cards, no cash, I'm afraid. So I think that's mostly around the fun part. I wanted to ask someone who's a much more fun than me, quickly just to get we're going to have a bit of a slogan over the next 3 days. So, and all of us are going to do this when the mood gets a little slow or things get a little tired. We're going to do our slogan here. Are we ready? And then you will say, yes, we're ready. We're ready for 2030. So Ruta's going to do one quick demonstration model.
Hi, everybody. Good morning to you all. My name's of Rutatina Edwin Moses, but let's go for Ruta. It's much shorter and easier. I sit on the Youth Advisory Board and my youth mentor. Yeah. Happy to have you today. Happy to have you today. Are you ready? And yeah, okay. Please stand up. Let's rise. Thank you. Okay. So we can now take our seats. Thank you.
Okay, I'm not sure. I think we've lost our PowerPoint. So that probably brings. Can we have the PowerPoint back on again? Can we ask the tech team to put the PowerPoint back on? That's, I don't think there's much left to say in that, but I think just exactly this is what we want to thank all our amazing partners and sponsors who assist to make the summit possible year on year. So a huge gratitude to all of them. And please also know that for all of the bios, all of the logos of any contributor, if you're a speaker, a chairperson, you've contributed in any way to the summit, you will find your bio and your logo on the Pata Hub, on the summit page. So thank you so much. You are acknowledged and appreciated. And back to Patrick.
A round of applause to Luan. So in Kiswahili, if I say panua, then hands apart. Panua? Your hands should be apart. And so when I say abstain, you know what to do. Abstain? Okay. You have not abstained. So you clap, hands apart. Panua? No. So panua means hands apart, right? Then when I say clap or I say ready, then you clap hard until your hands pain, right? Okay, panua, ready, panua, abstain. We don't want to abstain. Okay. Great. Our next speaker is Anna Yakusik, who is joining us from UNAIDS in Switzerland. She will provide an overview of where we are, identifying where we have unmet targets. We can only move and do well if we know where we are and fill the gaps. Unmet targets for children and reminding us on the urgency needed. Anna works in the data for development, and she holds MSc and MBA degrees and is a postgraduate student at Imperial College London Faculty of Medicine. Anna's work focuses on maternal, newborn, and child health and leads the monitoring and evaluation working group of the Global Alliance to End AIDS in Children by 2030. Join me to welcome Anna.
Thank you. Thank you so much. Good morning, esteemed colleagues. We're gathered here today to discuss a critical challenge, the persistent gap in achieving the global goal of ending AIDS in children and adolescents by 2030. The urgency is undeniable. This is what we see from our data and the scientific outcomes of our analysis. While significant progress has been made, far too many children and young people across African countries are still the most affected by HIV. My presentation will explore the complexities of this issue and highlight some critical gaps that we all need to keep working on. We will examine the data, which further underscores the need for urgent and coordinated efforts. Before we begin, I want to express our profound gratitude to all country teams and frontline workers, all the teams that work across Africa for their unwavering dedication and steadfast commitment to push through and advance our shared mission of ending AIDS in children, but also for collecting the data and for keeping on with HIV surveillance that informs our data and our messages. Your tireless efforts are the cornerstone of our progress. Behind the statistics are the countless stories of resilience and inspiration. And I would like to highlight one of them. The experiences of mothers living with HIV are a testament to their strength and dedication to their children. These stories drive our work, reminding us of human impact of the epidemic. Esteemed partners such as the Elizabeth Glaser Pediatric AIDS Foundation and so many others are instrumental in supporting these efforts. Let's just take a moment to reflect on the story of Elizabeth Glaser, and also just to acknowledge that ECPAF and the Population Services International announced the creation of Health X Partners Incorporated to further advance their impact going forward. Let's have a look.
Elizabeth Glaser. Giving birth to my first child, I hemorrhaged and was transfused with 7 pints of blood. 4 years later, I found out that I had been infected with the AIDS virus and had unknowingly passed it to my daughter, Ariel, through my breast milk and my son, Jake, in utero. Sometimes in life there is that moment when it's possible to make a change for the better. This is one of those moments. People say they care, but actions are what save lives.
There are 700 children who are infected with HIV every single day. Every one of those infections is preventable.
We've seen people living longer. We've seen children started on treatment growing up.
I'm alive today because my mother wouldn't give up. I'm proud to say that my name is Jake Glaser, son of Elizabeth Glaser. My mother wanted to make sure that no child had to die from HIV. Is this something that we can create? Yeah, for sure. I know we can do it. We have the science, we have the medicines, we have the momentum. We can eliminate pediatric AIDS. and all I knew.
Hi, Shem, sorry, we weren't actually able to, I think just the connection and showing the video from your side. But we will upload the video and be able to share it at another time, just so that we get some better quality. We also going to just have to monitor because we were losing you a little bit. So we're going to just see how that goes. Otherwise, we do have your pre-recording if sound continues to be a challenge. But please continue. Thanks.
Thank you, Lon, and apologies for these technical issues. So just to keep going, I wanted to highlight that it's been decades since the global community started working on preventing mother-to-child transmission. And important progress has been made so far towards ending AIDS in children globally. The data suggests that we have averted approximately 4 million new infections among children since 2000. And the availability of antiretroviral therapy has been transformative and instrumental in this success. However, this issue, the success doesn't negate the fact that significant challenges remain, and we must continue to build upon this foundation to eliminate vertical transmission. The downward trend in new HIV infections and AIDS-related deaths among children is encouraging. We have witnessed a significant decline in both in mortality and in new infections globally and across countries, and this success highlights the effectiveness of the ongoing strategies. However, the fact that approximately 120,000 babies were still infected with HIV last year globally underscores the need for sustained and intensified efforts. Most of these new infections occurred in sub-Saharan Africa. In 2023, approximately 1.4 million children and 1 million older adolescents were living with HIV. The alarmingly low rates of antiretroviral therapy coverage at population level, 57% of these children and 64% of older adolescents were on treatment. This highlights a critical gap in access to life-saving treatment, and the disparity demands immediate and concentrated action to improve testing strategies and access to care across the African continent and across African countries. The data paints a stark picture that children living with HIV are far less likely to be diagnosed with HIV and receive treatment than adults. In 2023, globally at population level, only 66% of children with HIV knew their status, compared to 91% of adult women and 83% of adult men. We need to prioritize diagnosis or early infant diagnosis and diagnosis across infants and young children during and after cessation of breastfeeding, and that's what our data suggests. Globally, the proportion of HIV-exposed children who were receiving HIV testing within the first 2 months of life has increased globally to 67% in 2023. However, this progress has been different across the Global Alliance countries. While early infant diagnosis coverage for infants has improved, misdiagnosis continue to present a significant challenge across all countries, especially in older children after breastfeeding ends. These misdiagnoses have serious consequences and directly leading to low treatment rates across countries and disproportionately high AIDS-related mortality in children, especially neonatally among infants and children under 5. Although the treatment uptake in children has improved clearly and treatment gap has decreased, we still have approximately 590,000 children without access to treatment and viral suppression globally. This persistent gap demands a strategic reevaluation of our current strategies across the Global Alliance countries and overall in all countries globally. Global Alliance countries are innovating to overcome barriers and accelerate progress to reach infants and children who were not identified during routine early infant diagnosis at 2 months, with additional opportunities to test for HIV, such as an example from South Africa, one of the Global Alliance countries. South Africa now has a policy of universal HIV testing of children at 18 months, regardless of a documented HIV exposure. Global Alliance countries are applying both service and technological innovations to reduce the rate of vertical transmission, including mobilizing mentor mothers, integrated and coordinated care for mother-baby pairs, and more frequent viral load testing of mothers, and also beginning planning for the potential future scale-up of long-acting injectable antiretroviral medicines to improve retention in care. The graph shows the coverage of services to prevent vertical transmission globally. We know that the coverage of this prevention efforts have plateaued globally, with rates at 84% in 2023. The progress is slow, and we have an area of barriers, such as structural and societal, and I will highlight those going forward in my presentation. Strategies are being rolled out to strengthen HIV prevention among pregnant and breastfeeding women, including adolescent girls, which includes partner testing, HIV self-testing, pre-exposure, antiretroviral HIV prophylaxis or PrEP, and various social, structural, and behavioral interventions are being rolled out. And of course, the global community is also making sure that the new solutions are available across African countries. This graph shows the number of new infections in children since 2010, while the number of children acquiring HIV in 2023 was the lowest, and this is a success, the lowest since the late 1980s. The rate of decline has slowed recently. We also see Western and Central African countries now account for about 41% of all children acquiring HIV globally. And we do need to concentrate resources and efforts across Western and Central African countries and sustain the results and success across Eastern and Southern African countries. Sub-Saharan Africa also remains the region that is most affected by HIV in terms of child mortality, and clearly reaching young patients remain a significant challenge at the population level. And due to the fact that a big proportion of children are not being diagnosed and not linked to care, the high number of AIDS-related deaths demands immediate attention. So over 85% of global AIDS-related deaths in children in 2023 was across Sub-Saharan African countries. Coverage of services to prevent vertical transmission also varies considerably across countries. On average, we've seen that the rates are much lower. In Western and Central Africa, 54% on average in 2023, compared to other regions. This disparity demands urgent attention, tailored interventions to address the specific contextual factors in Western and Central African countries to address this gap. Preventing vertical transmission also requires understanding of the underlying causes of vertical transmission and the transmission of HIV from mother to child. We do present this slide, the stacked bar analysis globally and by region, Eastern and Southern Africa and Western and Central Africa. We also have the stacked bar analysis for most of our Global Alliance countries and across the globe, across countries. So what we learn, and this stacked bar analysis is informed by programmatic data. So we learn and we can understand when the transmission occurs and also the risk of transmission to the baby across stages. So preventing vertical transmission requires a very comprehensive approach to maternal health and well-being throughout the pregnancy, childbirth, and postpartum, and especially postpartum, as we can see recently across countries. We must improve preconception counseling, ensure quality antenatal care, implement safe delivery practices, and provide comprehensive postpartum support, including throughout breastfeeding and testing strategies for kids after cessation of breastfeeding that I've mentioned before. The Global Alliance to End AIDS in Children, launched in 2022, was the result of the global push to eliminate vertical transmission in countries most affected by HIV among children. The Global Alliance aims to coordinate and collaborate across partners, countries, communities, to create a framework for accelerated progress, working with families, governments, and so many partners across the world. The Global Alliance is implementing the strategies to end AIDS and aims to end AIDS in children by 2030. The phase 1 countries focuses on 12 countries, accounting for a substantial proportion of the global burden of HIV in children. And you can see some data on the sides, and you can always, and I will present you the progress report where you can get more information across the 12 countries, as well as globally and across the Global Alliance as a group of countries. So this report, the 2024 Global Alliance Progress Report, launched in July this year, is the first Global Alliance Progress Report. It showcases both successes, achievements, and persistent challenges in addressing HIV in children and adolescents. And while progress has been made, the report also underscores the current pace is insufficient to reach our ambitious goals of ending AIDS in children by 2030, and the actions need to be accelerated. Declines in pediatric, if we look across new infections, declines in new infections, and declines in AIDS-related deaths in children, but also in adolescents, this graph comes from the Global Alliance report, we can see that the declines are positive. However, they are insufficient. Vertical transmission remains the primary driver of new HIV infections in children, demanding robust maternal health programs. Addressing adolescent HIV requires a comprehensive strategy and a different strategy that recognizes the varied pathways of infections in this group, vertical and horizontal. Progress towards eliminating AIDS in children tends to be greater in the range of the Global Alliance countries than in non-Global Alliance countries. And these improvements are the results of intensified national leadership and commitment, as well as the collaboration of diverse partners and communities to support innovation and scale up of proven tools and strategies. Also, significant progress has been made in antiretroviral therapy coverage across many countries of the Global Alliance, and especially in Eastern and Southern African countries. Globally, the number is 84%, as I showed before, but the 100% target remains unmet. Progress towards 90% of HIV treatment coverage is also too slow, particularly concerning the low access at the population level for children, 57%, and older adolescents at 64%. Viral load suppression is improving, but at the population level, it falls short of the 86% target for 2025. This highlights the critical need for effective pediatric HIV management. We do know that transition to dolutegravir-based regimens, along with enhanced efforts in adherence and retention, is helping to improve rates of viral suppression in children. However, further innovation, including through improved service delivery and emerging biomedical approaches, such as administration of long-acting injectable options, etc., has the potential to increase the rates of HIV viral suppression in children, but also in adolescents. Besides, something that I want to highlight here and carry on then with structural and social barriers for health is that the new infections among adolescent girls and young women globally and in Global Alliance countries, and the Global Alliance as a group of countries far exceed targets. In 2023, 210,000 adolescent girls and young women acquired HIV globally. far exceeding the global target of 50,000. This is alarming statistics, and it demands a comprehensive and targeted response, focusing on preventive efforts, specifically designed for adolescent girls and young women. We also presented this analysis this year that highlights that high HIV incidence among adolescent girls and young women is concentrated in specific regions, subnationally across sub-Saharan African countries. These areas require focused attention and targeted prevention programs. However, we've also learned from the analysis conducted this year that less than 36% of locations with moderately high HIV incidence have a dedicated program, and it is deeply concerning because it's really low for the locations with high and moderately high incidence in this group, adolescent girls and young women. And here I would like to highlight some social and structural determinants of health that we also view as a direct impact on continued HIV infections in adolescent girls and young women. Addressing the HIV epidemic requires us to also confront the complex interplay of social and structural determinants of health, particularly concerning gender inequality, stigma, discrimination, and violence among adolescent girls and young women. Violence against women is a pervasive issue, and it impacts health and vulnerability to HIV. Nearly 1/3 of women worldwide have experienced some form of violence, and this definitely needs to be addressed. And this is one of the pillars of the Global Alliance, pillar number 4. And I want to guide you through some data that's been pulled for the Global Alliance Progress Report in addressing pillar 4. IPV, or intimate partner violence, is a global pandemic affecting millions of women and girls, and particularly prevalent in sub-Saharan Africa and South Asia. The data shows that a significant percentage of women have experienced intimate partner violence within the last 12 months. And 26%, or more than 1 in 4 aged 15 years and older, have suffered violence at the hands of their partners or husbands at least once since the age of 15. Adolescent girls and young women are disproportionately affected by intimate partner violence. Almost 1 in 4 of adolescent girls have experienced abuse by the time they are 19. Intimate partner violence has severe consequences for physical, mental health, reproductive health, and it also increases HIV vulnerability. We must address the underlying societal factors contributing to intimate partner violence across our 12 Global Alliance countries and globally, including addressing harmful norms and lack of legal consequences. We've looked at some data that is provided by demographic and health surveys at population level and also across different regions. We've noticed that harmful norms that justify violence against women and adolescent girls are deeply ingrained in many societies, and not only exclusively by men, but also by women. These norms perpetuate cycles of violence, particularly affecting women in poorer households. Even in high-risk sexual encounters, women often lack control over decision-making due to societal norms, significantly increasing their vulnerability to HIV. About 1/4 of women in the Middle East, North Africa, and Sub-Saharan Africa feel unable to refuse sex, even if their partner has an STD or STI, sexually transmitted infection. When looking at the poorest households surveyed, it's indicated in Q1 on the graph, this share increases. In Global Alliance countries with available data, more than 2/3, 70% and more of women reported fearing intimate partner violence. This underlines the critical need for integrated interventions. The percentage of women using condoms during the last high-risk sexual encounter also varies across the Global Alliance countries, ranging from 22% to 65% in Zimbabwe. And this demonstrates the crucial need to address societal and structural barriers that hinder consistent condom use. in most of the countries across the Global Alliance in high-risk sexual encounters. Among women with multiple partners, condom use rates are also similarly low in most Global Alliance countries. This points to serious consequences of risky behavior and the need to address societal and structural barriers across the Global Alliance countries. And I do highlight this because we do see that many women get infected during pregnancy or postpartum and transmit unknowingly the infection to their babies. Arguably, many countries with high prevalence of intimate partner violence also have a higher prevalence of women living with HIV, and Sub-Saharan Africa on this slide is highlighted in yellow. This analysis was pulled by the World Bank Gender Data Portal. So what we did for the Global Alliance Progress Report, we've also looked at the very recent platform, the World Bank's Women, Business and the Law initiative that highlights the critical importance of women's safety, and it advocates for policies that promote gender equality and safety. The safety indicator delves across many questions and into a systematic analysis of laws and policy instruments, addressing 4 pervasive forms of violence against adolescent girls and young women and women in general: child marriage, sexual harassment, domestic violence, and femicide. What we learned from our analysis that focused on 12 Global Alliance countries based on this safety indicator, that across 12 Global Alliance countries, we've noticed a critical lack of legal protection across different strategies. We've only pulled some key questions that we wanted the world to have a look at, and specifically the country teams, and we keep promoting this analysis to be taken forward. We've learned that significant gaps exist in laws addressing sexual harassment, including in schools and educational settings, domestic violence, marital rape. Furthermore, none of the 12 Global Alliance countries have laws specifically addressing femicide. This absence of legal resource, combined with harmful cultural norms, contributes to higher rates of intimate partner violence across our 12 Global Alliance countries, and consequently increases HIV vulnerability among women and adolescent girls. We must strengthen our legal frameworks and challenge harmful norms to safeguard women's and adolescent girls' safety and well-being, and focus on societal and structural barriers, similarly as we do focus on clinical response. Achieving the goal, in conclusion, I just want to say that achieving the goal of ending AIDS in children demands gender equity and empowerment. This necessitates timely access to HIV services, robust maternal health programs that address the full reproductive life cycle, enhanced support for adolescent girls and young women, particularly in Sub-Saharan Africa, and policy changes ensuring gender equality and protection from violence, including gender-based violence and intimate partner violence. Only a multi-sectoral approach that tackles root causes will lead to elimination of pediatric and adolescent HIV. I thank you for your time and attention. We do need and we must continue working collaboratively. Let's utilize some resources that we've pulled in our key 2 publications this year, The Urgency of Now and Transforming Vision into Reality, to guide our continued efforts. Thank you.
Great. Thank you. We've seen the unmet gaps, and the question to all of us is what proportion of that data does your country contribute, or your health facility? We have to be that granular for us to have an impact. Our next speaker is Dr. Shafiq Assaji, who will provide an overview, I would say a continuation, just to dissect the Global Alliance progress that has been made so far, and how we turn our vision of the Alliance into reality. Dr. Shafiq is a long-serving member and chair of the PATA board but many of us know Dr. Shafiq as Senior Advisor of UNICEF's Global HIV/AIDS Program. He's a clinician, scientist, and public health specialist with over 20 years of experience caring for children with HIV in New York and previously in Kenya. Join me to welcome Karibu.
Asante sana, Patrick. It's a pleasure. Oh, I think this was set for Ruta. Now we come down. It's such a pleasure to be with you. My name is Shafiq Isaji, and I work for UNICEF HQ in New York. But I'm a Kenyan. I used to be an active participant of PATA on that side of the podium as a frontline provider. And I hope that my reflections today will come to you from my global position, but also remembering my roots with you with providing services. You know, it was almost 40 years ago that the first cases of HIV in children were described in the medical literature. Not a lot of people know that. They think, oh, the kids came later, but they didn't. They were some of the earliest cases that were described. And in fact, it was because we realized that HIV was being reported in children that we realized that HIV was transmissible and that it was an infectious disease. Before then, there was a lot of argument. People thought it was a lifestyle disease, an NCD, because of drugs or toxins in the environment. It was because children were getting AIDS that we realized, oh no, this is an infectious problem. And soon after that, the virus was identified. So kids were there from the very beginning, but as you just saw in Anna's presentation, kids have been left out since the very beginning. And now we have rates of coverage in adults that seem impossible. 87%, 95% of pregnant women living with HIV are accessing treatment. That's common in our parts of the world. But for children, we are still stagnating. Now, the Global Alliance, which you all have heard of by now, is our latest effort from the global level, following on from the Global Plan and the 3 Freeze Initiative to try and address this imbalance between adults and children, between prevention and treatment. And the vision of the Alliance, which I've written up there for you all to read, is to achieve an end to AIDS through coordinated action that brings many stakeholders together, working with communities of women to end AIDS in children. And I just want to highlight a few key points, because I know that we're going to keep coming back to the Alliance. In fact, it's a theme that will run through and structure the way the summit will operate. So a couple of things. First of all, the Alliance goes out to 2030. All right. In previous years, we had these shorter initiatives. The Global Plan was 5 years. The 3 Freeze was 5 years. When we launched the Alliance, we decided, no, let's go out to 2030 and let's really build momentum over a longer period of time. These shorter term initiatives are not working as they should. Let's see if a goal that is set to the end of the Sustainable Development Goals might work better. The Alliance seeks to be pretty comprehensive across 4 pillars of work. And again, you will come back to these over the course of the summit. But essentially, pillar 1 is about treatment coverage in children. How can we close that treatment gap? Pillar 2 is what do we need to do to finish the business of preventing vertical transmission of HIV? Pillar 3 is about preventing women who are negative at ANC from acquiring HIV during pregnancy and breastfeeding. And pillar 4, the last pillar, but in some ways the most important, is to address stigma, to address gender equality, to bring communities into the front line and try to tackle some of the structural and social barriers that are hampering access. You'll see at the bottom, there's a range of different partners. These were the founding partners, if you will, of the Global Alliance. But if you can click on the next slide, I want to underscore that PATA, while it wasn't there at the very beginning, is a critical partner of the Global Alliance because it's literally the engine of how this work is going to get done. All of you are the engine. We may occasionally put some fuel into the tank. And we may be looking at the map saying, go this way, go that way. But it is your engine that is going to drive us to success. The Alliance was launched in 2022 at the Montreal AIDS Conference. And soon after that, it was endorsed by the 12 inaugural countries in Tanzania. And it has definitely increased political momentum. I hope you're all feeling that in your places of work. At the Dar es Salaam meeting, action plans were endorsed and refined, and the 12 ministers of health signed the Dar Declaration. This makes 10 commitments, and among them, it's to ring-fence money for children, to put communities in the lead, and to end the stigma that hampers our progress. So they were pretty serious commitments, and your ministers of health have signed on the dotted line. Countries have now integrated these action plans into their Global Fund proposals, into their PEPFAR COPs. PEPFAR is a key partner within the Global Alliance. So a lot of the ducks are lined up. And in countries, national alliance teams have formed, and at the regional level, we have formed technical hubs for Eastern and Southern Africa, for Western and Central Africa, to continue to provide countries with the support that they need. Next slide. So in the past 2 years since the launch, what progress have we actually made in preventing vertical transmission? This is pillar 2. And there have been some notable successes. Now, this is a very busy, complicated slide, so let me try to break it down for you. You see countries of the Global Alliance on the left, and the bars to the right in dark pink and light pink represent the vertical transmission rates from pregnancy and breastfeeding. And there are 3 bars for each country. The top bar is 2015 data. The second bar is 2021 data, and that is the baseline data for the Global Alliance. And then the lowest bar is the data from 2023. So what is it showing you? Next slide. I think there's only 2 countries that have made really significant progress, and those are the countries in green, Kenya and South Africa. Kenya managed to drop their rate from 10% to 7% since the Global Alliance baseline. South Africa went down to 2%, which is actually a remarkable accomplishment in a country that has the largest number of pregnant women living with HIV. Now, the countries in red, next slide, have made poor progress or are doing really badly. All of these are from West and Central Africa, my brothers and sisters from West and Central Africa. Nigeria it remains one of the key challenges, 23% vertical transmission rate. DRC is one of the worst performing countries globally in this ranking at 26%. And in Cote d'Ivoire, there was an apparent increase in the vertical transmission rate from 7% at baseline to 10% in 2023. So I think we really need to try to unpack some of these challenging countries to try to understand what is driving them. And I hope we get to that during the course of these next 3 days. The remaining countries, next slide, I've given them an orange rating because they're making some progress, they're moving in the right direction. But is it fast enough? Is it far enough? And when you look at what Kenya and South Africa did, I have some ideas for us to reflect on why they have achieved this success. Next slide. So in South Africa, the rollout of PrEP amongst pregnant women who are HIV negative at ANC. Next slide. The rollout of PrEP has really advanced very significantly. This is a recent paper that highlights that now 91% of eligible pregnant women who are HIV negative are getting PrEP when they show up in ANC, and they're staying on PrEP throughout pregnancy, throughout breastfeeding. I'm sure that this has contributed significantly to that drop down to 2% vertical transmission rate. Kenya did a remarkable thing. In 2023, next slide, they launched what they called a Rapid Response Initiative, an RRI. This was 100 days where they went to every single county across the country. They looked at the situation, they identified the challenges, and they made a rapid response. And as a result of this, and I think we're just beginning to see the outcomes of this. Remember, this was done in 2023. So the new kids that are born as a result of that rapid response initiative will only be counted in 2024. So I think we've not even seen the full impact of this RRI. But what it shows us is that when you undertake efforts to attack a problem with intensity, with interventions, and with investment, you can really make a difference. So what about the actual treatment of children, so-called Pillar 1? Next slide. Unfortunately, the results for Pillar 1 are much less impressive. And remember, this is kids we're talking about. This is kids living with HIV who should be on treatment. And what this graph shows you, it's again taken from Anna's amazing report on the progress that we've made in the Global Alliance. It shows you ART coverage of the 12 Global Alliance countries over time. And while the curve for children has increased and is now at 57% in the Global Alliance countries, the curve for adults has accelerated, and in fact, the gap has gotten even wider in the Global Alliance countries. So I think we really have to question this and say, you know, why are we making such rapid progress in adults, and why are we stalling in terms of our progress in children? We're going to explore these in detail over the course of the next 3 days. But let me give you some top-line thoughts. Next slide. Now, it's always challenging to ask the million-dollar question of why. And in a presentation like this, there's a tendency to oversimplify, and these are very complex issues. But I want to try to be a bit provocative and get all of us and get you thinking about some of the reasons. So the first issue is money, right? We've made all these commitments and promises, but there's no new money. There isn't going to be any new money. Apart from the 7 countries that are part of the PEPFAR surge, we haven't seen any major new investments in HIV coming from any sector. We keep trying, we keep pushing, we keep knocking on the doors of the big funders to say, hey, you know, pediatrics is still a problem, HIV is still a problem. But we haven't seen that level of new investment. And I think if we're going to wait for money, we're going to run out of time. So we have to figure out ways to get smarter and develop new models for HIV that are less expensive. Next slide. The second issue is I think that we are not spending that money very wisely. You see, this is not projecting as well as I'd hoped, but well, not a problem. And here's a great example of how we're not spending money wisely. Treatment is what we measure, but how you get to treatment is through testing. And the thing that we're measuring is EID coverage, but EID is not going to get us to the coverage levels of treatment that we need. Not on its own. If you look at the UNAIDS data, 60% of the kids that are living with HIV who are not on treatment are between the ages of 5 and 10. They're not going to be getting tested with EID. So we have to think of other ways to test these kids and strategies that many countries have piloted and pioneered like community-based index testing, where women living with HIV, Tanzania has done a wonderful job of this, and I'm proud to say that UNICEF supported this effort. Community workers, women living with HIV, went door to door among their community, telling people to test, advising them to test, looking for cases, and they found extraordinarily high numbers of undiagnosed children who were older, who needed to be started on treatment. They also found lots of kids who had no vaccines, kids with malnutrition who clearly needed nutritional support. So we need to bring the community in to help us to achieve this and other related health goals. Next slide. We focus on the shiny new things like dolutegravir, right? A few years ago, it was the promised land of dolutegravir. It was going to save us. And of course, dolutegravir is a fantastic, fantastic drug. Those of us who've treated kids, who are on the front line, treated mothers, have seen this effect up close. But you have to take the drug in order for you to respond. And when you look at that stack bar analysis across all of our countries in the Global Alliance, 35% of all the new infections are among women who you tested, you found them, you treated them, but you didn't keep them in care. And the community always says to us, don't tell us we are hard to reach. It is you who are not reaching us. You are not reaching us. We're not hard to reach. We're here. Bring your services to us. Back in the 1990s, when President Clinton was running for office and fighting against George Bush, he coined the term, it's the economy, stupid. Well, I say to you, it's lost to follow-up, stupid. None of you are stupid. I think you know this. But let's look at the obvious things. If we can fix the loss to follow-up, we can actually maximize on that investment, and we can immediately stop 30% of the new transmissions that are occurring. Thank you, sister. From the Ministry of Health, ladies and gentlemen. and the last slide, which you can't quite read, but I will read it to you. The global machine can't make change happen. Without you and without community partners, we are nothing. And I say this as one of the architects of the Global Alliance. You can't make change happen at the global level without your commitment and determination to put your local solutions and strategies in place, to push your leaders to make their commitments come to life, to join arms with your brothers and sisters in your communities affected by HIV. Ending AIDS will remain an impossible dream. So the last slide, let me close by coming back to this image that I showed you at the start. And this time, let me focus on the story of this image, because these are people. This is Katerina and her son Wilter, and they're from Mozambique. Katerina is a woman living with HIV on treatment. Her son is HIV-free. She's a healthy young mom who works as a mentor mom in her country to support other mothers and children to live positively. And you can see that positivity in her smile and in the healthy, loving relationship that she has with her child. This is really what we want to see for every family that we deal with. My first PATA summit was 20 years ago. So actually, I think I've been doing this work for over 30 years. It was in Cape Town in 2005. And it was so exciting to gather, to meet each other, to share experiences, to inspire each other. And I hope that when you leave this place, you too will learn and get to grow from the experiences of sharing each other's lives. And you too will come away with commitment. So I hope that you are ready, because the time is now. We've got 5 years left before the end of the SDGs. If we want to get to those goals, we have to accelerate our action to end AIDS once and for all. Thank you very much.
Asante sana. That means thank you. Is lost to follow up stupid? That's what I picked. without you, without the community partners, we are. So that's how valuable you are. Let's give another round of applause to you. It's important to hear from the countries, and we would have loved to have each country tell the story here. But you still have an opportunity to tell your story in the African Cafe. Right? Great. So this time I'm going to invite South Africa, and that is Gugu Shabangu, who is the Chief Director for HIV and AIDS and STI in the National Department of Health. Our portfolio includes providing strategic direction in the management of HIV and AIDS and STI in public service, having served in the office of the Premier and spearheading HIV response and service improvements in KwaZulu-Natal. Welcome.
Thank you very much, Program Director. I would love to greet all of you in the wonderful name of my Lord Jesus Christ. Amen. Thank you very much. With a special greetings to the Ministries of Health in the room. Greetings, the PEPFAR leadership. Thank you very much for pulling all this together for us. And the partners that are supporting the children, especially UNICEF and everybody else that loves the children. Greetings. And all the countries that are here in our country, in our beautiful South Africa, we welcome you and we greet you. And the civil society that is amongst us, the beneficiaries, if we have anyone that is representing children and adolescents amongst us, and the healthcare workers, our loved ones, we wouldn't be here without you. I would love to greet all of you. I think we can have a very big round of applause. Thank you very much. To the operator, I just want to see my slides closer. If you can just move with me as I'm moving my slides. Thank you. I will just give a very broad overview. I know there's a lot that is going to be discussed in the groups in terms of our context as a country and where we are. I know UNAIDS, Anna has shared some light in terms of our statistics and how we are doing, and all other presenters, especially on the vertical transmission. We've done some strides all over there, but there are also other areas that we've done well, though we still have challenges. This is our context in terms of our HIV. We have 7.8 million people that are living with HIV in the country. And when we look into that, only 5.9 that are on treatment. So we have a gap. And this is the total population, including our children, that are amongst these ones. But the bigger gap is within the children. And when you look into our gaps also, we have not done well when it comes to the second 95, and we've only managed to achieve the first 95. And when it comes to those that we have retained in care, we are still at around 80%. But also it is pleasing to know that amongst the ones that are on treatment, the 5.9 million, 4.4 million are ready to be decanted for treatment outside our health facilities, just to decongest our health facilities. The health workers in the room will know that there's nothing that we need more than to decongest, and also to provide closer to the people, including our children. They also want to take their treatment closer to their homes and in their comfortable space. So we're trying to do that as a country. We have moved a mile, but we do have a 1.1 million treatment gap that we have. And the main contributing and why we have this 1.1 million treatment gap, mainly still the stigma and discrimination. And when you look and have discussions and dialogues in our communities, the internal stigma is still a main challenge. And this is affecting also our mothers. They don't disclose, they don't get support, and this affects them during the time of pregnancy. And even when they deliver babies, they don't get support that is necessary because they also stigmatize themselves and they have not disclosed their status. So we are dealing with a lot, and it's just coming out so frequently. We just don't know. We were just saying maybe we need a study because previously we were haunted by the external stigma, but all of a sudden we see a lot of internal stigma and a lot of mental health issues around our people living with HIV. So we are faced with it, and that is what we are putting ourselves and all the strategies around it. And also the issues of treatment interruption around, especially before 12 months. And that is a very critical time for the mother and the baby. And we are seeing a lot of disengagement on treatment during this time. And the gender inequalities, I think the previous speakers have mentioned that as a country as well, we are also faced with the gender inequalities, especially the adolescent girls and young women that are mostly affected, the issues of poverty that are affecting our children, and them not be able to access treatment to the areas where they are. So issues of gender inequality, we are actually dealing with that, and we are happy that UNAIDS is actually coming up with a lot of strategies and policies around how we can deal with the issues of gender inequality. And as a country, we've adopted that, and we are moving with it. And also the issues of meaningful involvement of people living with HIV, all of our children, because all of the time we talk about adults when we talk about engaging in actually greater involvement of people living with HIV, and we forget about children. And we hardly have platforms where we engage with children. We hardly have platforms when we actually have what they call it, the camping, where we camp with children and then we actually make them and simplify the issues of HIV with them. I've seen it in India, how they actually do it very simple, and how they engage children in their journey of HIV. And we tend to focus more on adults, yet we also need to be engaging children. So these are the dominant subpopulations that we are seeing a lot of gaps, especially children. So we have taken a position as a country that much as we are seeing a lot of gaps around children, but let us treat the children in the context of the family. The children is not alone. There's a mother, there's a child, there's a granny, there's a caregiver. So we need to treat them in the context of that. And we need to find out what is happening with the mother, what is happening with the father, where is the child in the midst. So we have learned that most of the men are not taking treatment. Young people, including our adolescents, are not taking treatment. They've disengaged on treatment, and also our children. We have put some key high impact projects as a country, and we've adopted Global Alliance to End AIDS, as it has been said. Our patriot is our spouse to the Deputy President, Her Excellency Humile Mashatile. She's the one that is championing the issues of the Global Alliance in the country. And she's working with the whole team that is also pushing that. And we are hoping that by the 2030, we will be seeing some strides. We've adopted the Global HIV Prevention Coalition, where we are dealing mainly with the issues of combined prevention strategies. And somebody mentioned PrEP as a country. We are hard on PrEP, we are big on PrEP, we are pushing PrEP, and we are ensuring that all our mothers are taking PrEP whilst they are still pregnant, so that they prevent the vertical transmission. So we are actually, these are the main impact projects that we feel that if we as a country continue to apply and expand on them, we will see some difference. HIV and CP accelerator commitments, we are working with PEPFAR on this one, and the children is among the commitments that we have made. And every time we sit and review how we are actually dealing with and closing the gap within the children. And also we've identified the key facilities, the high burden facilities within the country, and there are hundreds of them. And amongst those facilities, we look and zoom down into the data and actually find out how then the facilities are tracing and closing the lost to follow-up gaps. And in those facilities, we ensure that they are well-resourced, they are healthcare workers, and as well as community healthcare workers that are able to link us with the community, and how then we trace the clients from communities. And then we have learned that us not having an electronic medical record has caused a lot of problems. We've lost a lot of data, and some of the clients we've thought we have lost them when they are sitting in the system because the data, we are losing a lot of paperwork. So we are now trying to move to the electronic medical record, and we feel that once we have that, we'll be then able to connect even the facilities and be able to trace our clients where they are, because some of them, you find that they are lost to follow when they've just gone to another province or to another country. So we are trying to ensure that we connect. We have our national strategic plan, which is guiding all our practice, and we have all those goals. But amongst that, we just want to say that the children, the issues of children are appearing in each and every goal, and they are very explicit in terms of what needs to be happening with the children. And in this national strategic plan, the priority is the children, and we've put them in the center of everything that we'll be doing as a country. If I adopted the Global Alliance, I've already indicated the first, the second, and the third pillar are mainly for the Department of Health, where I'm coming from, and with the colleagues that are also here in the room. And then on the fourth pillar, we work on it as a multi-sectoral, mainly driven by departments like your social development and other departments. So this is how we have positioned ourselves as a country. I will run very fast on these ones because I just wanted to show you that as a country from July 2024, in terms of our total population, we have not reached our second 95 as well as our third 95. We're very close to the third 95, but we know that the third 95 depends on the second 95. So we were at some stage 80, so we've dropped because State SA has moved the population to 60 million. So we've now seen a decline. We've gone to 79. We are working very hard, as I'm saying that we have committed on the accelerator. These coming 6 months, we are actually pushing as a country. We are very clear. We have met with all the 9 provinces. We've identified the areas. We have met where are these people that have disengaged on treatment. We know them. We have said we are going to be going out and trace them and use every resource that is out there to ensure that we get them back on treatment so that they don't continue and infect other people. So we have a very clear plan in terms of this. We are not so sure whether we will be able then to achieve the second 95 come the end of 2025, which is the UNAIDS targets. So, but we are pushing and doing our best. But we are also saying that that gap of 1.1 million, that is what I'm talking about. We have distributed it across these months, and we are trying to push it. And those are the people that also qualify to take their treatment outside the facilities. I want to rush to the children. Here are the children. You saw when I was showing this, it's 96, 79, and 94. But when it comes to children, there's a big gap. It's 87, it's 80, it's 70. So the speakers that have already indicated that we are not doing well when it comes to children. We've neglected the children. So as South Africa also, we are not proud of what we are seeing, but we are happy that we have a plan to actually work together and close and get these 31,242 children back on treatment and move everybody else to 95, 95, 95. These are our adolescents, which are also not doing well when it comes to 15 and 19 years old. We are also not yet there when it comes to the 95, 95, 95. When it comes to the vertical transmission, the national maternal HIV viral load suppression and the delivery were sitting at 88%. So this is just to show that as a country, we are also trying our best to improve on this one. And the syphilis, antenatal client tested for hepatitis B as well as for the syphilis screening coverage. With the hepatitis B, it's a zigzag picture. But when you look into the syphilis, we are starting to go up as a country. And this was discussed also with the provinces. And provinces could share their plans, how they've improved the syphilis screening coverage in their areas. So we are really coming up very well when it comes to the syphilis. And we have guidelines, very clear guidelines. We've got a lot of guidelines, and we capacitate our healthcare workers when it comes to updating the guidelines and so on. We are not yet there. We are at the bronze tier, but as soon as we are certified, we will then be working very hard to move from the bronze. But this is what we just wanted to show, that as a country, we are still at a bronze tier. We have managed to achieve some of the things. We've managed to sustain our HIV testing treatment in antenatal care for above 99% for quite a number of years now. We do have gaps, but we are saying we have also improved on the TLD coverage, especially for women of reproductive age. We have started our implementation of PrEP, as I've indicated, especially for the pregnant and breastfeeding women. And we have sustained our early infant diagnosis testing at 100% as a country, and we've sustained our PCR positivity at 0.5 across all testing algorithm age groups. This did not just come easily. There was a lot of work that has been put in. There was a lot of support in the facilities, training, working together, being supported by our PEPFAR, our Global Fund partners and everybody, and as a country pulling together to ensure that we really make sure that we achieve this. So I just want to thank our healthcare workers. I think they always deserve a round of applause, not in South Africa, but everywhere else. These are our challenges. I must also finish. We do have a low case finding, especially for children, I've already indicated, and the prior linkages took in some of the areas. As I'm saying, we've identified those areas and we've put plans in place, and the gaps in treatment and initiation, especially for the men and as well as the children and young people, and the high loss to follow up, as I've already indicated. We've put some solutions in place. I think the first one is our accelerator commitment that we have made, and we are working closely with PEPFAR on that one. We are saying we can increase the case finding. We have mapped where men are, we've mapped where children are, and we are working with the people that are influential in our communities, traditional leaders, traditional health practitioners. Everybody can assist us to trace children, men, and young women, especially on Ndlunkulu, the wives to the kings and so on. They have influence in our communities. So we've engaged them to say we really need to bring in the children closer to us. So we have also strengthened our nerve center approach, and we have just launched the second and the third nerve center. We only had as a country the nerve center that was looking at the treatment and care, but 2 weeks ago we've launched the nerve center that is going to be looking at the Global Alliance indicators, and the team have been pulled together to actually design the dashboard. So the country will be having dashboards moving forward and looking into the data for the Global Alliance and using our country plan. I hope most of you have seen the country plan. If not, I hope the team that is here will share some copies and show you how our country plan looks like. It's beautiful and it's very clear and straight to the point in terms of what needs to be done. So part of that is then us establishing that nerve center, which is going to be sitting on a monthly basis at a level of where I'm sitting with PEPFAR, co-sharing, and then our DG getting the information on a monthly basis in terms of how we're doing with children. And then we are also going to be strengthening our campaigns, including our welcome campaigns and all other campaigns that we have been doing. So on this one, I will really run fast, but these are the main things that are in our plan. As you will be taking our plan, you'll see that in terms of our pillar, we will be strengthening our routine HIV testing. We will also be ensuring that on the second 95, we ensure that we increase access, especially for our children when it comes to the treatment. And also in terms of our third 95, ensuring that we produce a quality viral loads and supports everyone. And then on the pillar 2, also, as you can see, we're generating the demand for the DTG and also ensuring that there's a structured package of care, especially for the breastfeeding women. And also, I'm just running fast because these you'll find in our plan. And then for the pillar 3, we are saying we are wanting to scale up the integrated and differentiated service models for PrEP and for all the treatments so that our children as well as mothers are able to take the treatment in our communities. So as I'm thanking you and I'm sitting down, I want to say that we believe as a country that the inequalities which drive the AIDS pandemic are not inevitable. Policy implementation can overcome them. So where we are sitting as a department, we are responsible for policy implementation, we are responsible for policy development and capacity building. So we will be working closely with the healthcare workers and ensuring that we beat the inequalities which are driving the AIDS pandemic. And I want to thank all the countries that are here, and we are looking forward as a country to learn from you, especially those countries that have got limited resources, but we are seeing better and good outcomes out of them. As South Africa, we are here to learn from you. Thank you very much.
Thank you, Mrs. Shabang, for sharing that with us. And we are all here to learn. So prepare your questions. Apart from question time here, you can always reach out to learn from the various countries. Lastly, we will invite Dr. Amen from the National AIDS and STI Control Program as part of the Federal Ministry of Health in Nigeria to share an update on Nigeria's Global Alliance country plan. Dr. Himen is a passionate doctor interested in children and adolescents living with HIV in Nigeria, and he has contributed to the developments of various policy documents and guidelines in Nigeria. Welcome.
Thank you, Patrick. Thank you, everyone. I'm pleased to be here to share our experience. I'll be standing on existing protocol that was established by Ms. Gudu. So thank you. For us in Nigeria, we embark on this global alliance because of the challenges that we're facing as a country. We're glad that it was launched, and we're part of the phase 1 country that started the alliance in Nigeria. For us, what we did a bottom-top approach in the sense that we enabled our subnationals to develop their own state-specific plans that is in tandem with their data. And at the national level, we had a consultative meeting where we came up with a national plan. And good to say that we involved all critical stakeholders in developing the Global Alliance Plan that is aligned with the 4 pillars that we all know, from pillar 1, 2, 3, and 4, with the same vision. And that vision is that for us to end pediatric AIDS come 2030, all hands must be on deck, because the government cannot do it alone. We need the collaborative efforts of everybody to do it. As you all know, Nigeria is a very big country with over 200 million total population and 1.9 million people estimated to be living with HIV. And currently, we are having 1.56 million people that are currently on treatment. And so before we started, this was our baseline as our 2021. Our EID coverage was 15, 18 months final status for infants exposed to HIV, as you can see, 79. Our coverage was 25 for pediatrics, which is very low. For pillar 2, for the ART coverage amongst pregnant and breastfeeding women, it was 34. For pillar 3, the retesting rate was still low, 1.8. But for pillar 4, the ask from the Global Alliance in terms of the indicators were doing quite well. So when we did the deep dive analysis, we discovered that across board, we had some specific issues allocating to each of the pillars. For pillar 1, what stared us at the face was the suboptimum testing of children from PLHIV. And there's low testing of children across our service delivery points. And the low testing coverage was still low, and retention was also an issue for pillar 1. For pillar 2, we had issues with our service delivery coverage for PMTCT. We still had issues on retention. For pillar 3, there was limited retesting, as I earlier alluded to, and limited PrEP operationalization for pregnant and breastfeeding women. For pillar 4, we also discovered that the low uptake for ANC was due to the costs associated with it. And so we started battling, trying to see how we can come up with various innovations to help us mitigate the gaps. This is just our target versus performance over the years. For the EID, we've moved the needle a little bit, from 15%, it came down to 12%, and then as at last year, it's 18%. For the 18 months final status for the HIV exposed infants, of course, we progressed, came down, and then it went up again. For the coverage, we started at 25, moved to 26, and as of last year, we're at 29. And the same goes for the rest indicators there. So currently, as at last year, for children less than 15, we are still at 35. As the first 95, second 95, 84. And then for the last 95, we're at 88%. However, for the general population, we are at 89% for the first 95, 88 for the second 95, and 95 for the third 95. So you can see that for adults, generally, we're doing well, but when it comes to pediatrics, that's where we're having the issues. And so we focused on pillar 1 to see how we can be able to change the narrative. How do we effectively diagnose children, link them to care, and ensure that they are virally suppressed? So we came up with activities that will help us address this gap for pillar 1. We discovered that our PLHIV, we have not explored the options of testing all their children. So we've started that in country. We're also having issues with reporting, and that is addressed currently. And the testing kits also pose the challenge. Most times we are out of stock of the testing kits. The kits are not really there, but I'm happy that with the support of PEPFAR and with the Global Alliance, the Global Fund grants that we are currently implementing, that is changing. And we've been able to conduct need assessments to how to reach areas to see how we can be able to deploy point of care so that the EID can be done in those areas. And we've been able to also distribute POC machines that was procured to all these areas as well. And we discovered that we have a lot of GeneXpert machines. It would be nice for us to optimize them so that the GeneXpert machines can also run EID, and that is currently ongoing. And we've made tremendous improvements in those areas. So we looked at the testing of children of PLHIV, and we wanted to do that at the national level because our implementing partners have been doing that across board, but we don't have that data reported in our NDR. So we decided as a national to go all out and see how we can explore these low-hanging fruits. We know that we are supposed to launch out to the communities and test to see how we can improve our coverage. But let's see how we can explore testing children of PLHIV so that we can be able to close all the gaps there. So this just shows the necessary milestones that we've achieved from June to date. And we have started seeing results pouring in as a country. This is just the dashboard, because what we did was we have what we call NDAS. It's a national reporting platform developed by NASCAP to really harmonize all the national data into one platform. We've done that, and in that NDAS, we're able to create a module for family index testing. So from there, at the national level, we can now monitor what is happening across as a subnational. Okay, so this is just a snapshot of the dashboard at NASCAP, where we see real time how this family index testing line listing is ongoing because we said it's a low-hanging fruit and we wanted to just leverage on it and see how that can help us improve our coverage for pediatrics. So I'll also focus on pillar 4. Oh. No, I've gone ahead. I'm in pillar 4 now. Sorry about that. Yeah. No. Is this the slide? I'm in pillar 4 now. Oh, no. It's not moving. No, this is not it. This is the wrong slide. No, this is the wrong slide. Yes. Yes. So apologies. They've been projecting the wrong slide. Okay. 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 All right, apologies. So can I connect directly since they don't have the... Okay, let me just continue. So on pillar 4, we actually focused on 2 interventions because we discovered that the uptake of care is low and there are a lot of barriers why folks are not taking up care. And we are looking at 2 major interventions. The first is how do we utilize our community structures to ensure that we address sociocultural barriers to antenatal and to PMTCT. The second intervention we are looking at in pillar 4 is how do we minimize the out-of-pocket expenditure so that people can be able to access PMTCT and pediatric services. And so we've been able to achieve some milestones using the first intervention in pillar 4 I spoke about. We've trained what we call wards development committees at the LGA level so that we can leverage on that structure to address the low uptake or coverage of PMTCT across 20 states in Nigeria. We've been able to train about 3,510 WDC committee members, and we're beginning to see the results in the uptake of PMTCT at the local government level. We also developed and deployed a community-led monitoring tool and app, and we've been having meetings with NEP1, ASHWAN, APYN to discuss on pillar 4 and how to move the global alliance forward. And we have improved male engagements to address gender inequalities in pillar 4. For the second intervention on addressing out-of-pocket expenditure, we discovered that it would be lovely if people living with HIV in Nigeria are all enrolled into what we call the health insurance scheme. It has been changed to the Health Insurance Authority in Nigeria, We want to see how we can enroll them into that, because if we do, it's going to reduce out-of-pocket expenditure, and that will also encourage folks to access care. The second strategy we are also deploying in this intervention is to see how we can integrate HIV service, because now in Nigeria, we are discussing about going into sustainability of the program. For the past 2 decades, thanks to PEPFAR, thanks to Global Fund, they've really come in to help us. But we are taking a lead now. How do we sustain the gains? And one of the ways of sustaining these gains is to ensure that PLHIV, the HIV services, is integrated into the mainstream. Because if that integration is done, we will not have standalone parallel programs across our facilities in Nigeria. So that conversation is ongoing, and we are happy that we've been able to achieve a lot when it comes to service integration. So we also developed a coordination platform for the Global Alliance. That was missing. This year, we're able to, at the national level, we have a platform that is chaired by the Honorable Minister himself. We have the DG NACA, we have the NC of NASCAP, we have colleagues from UNAIDS, PEPFAR, Global Fund, WHO, as part of that coordination mechanism at the national level. And we further subdivide the coordinating mechanism into two. A group will be focusing on pillars 1 and 2, and then another group will be focusing on pillar 3 and 4. This will enable us to really address the challenges that we are having in country. So the group addressing pillar 1 and 2, they are the service delivery team, while the group addressing pillar 3 and 4, they are the multi-sectorial team. So we have a lot of challenges. One of them is that at the subnational level, we still need to build capacity. Second is we need our caregivers to be literate enough on what HIV is all about. Thanks to what NEP1 is doing through the community-led monitoring, they've been able to expand that literacy base across board. And we are also having issues with reporting and documentation, like I earlier alluded to. So those are some of the things we are trying to overcome. And what have we learned? We have learned that community programs is the best way to go. It's something that we can lean on. It's something that we can take advantage of in trying to address barriers to ANC and PMTCT. And like I said, as a country, we are looking at sustainability. We are trying to strengthen our existing structures. We are not interested in creating new ones. The problems we have, we can solve them with the existing structures that we have. And we believe that with this integration coming on board, enrolling PLHIV into the health insurance scheme is going to go a long way in helping us address issues with Pillar 4. Thank you, everyone.
Thank you, Dr. Himen, and sorry for the yeah, we'll ensure that the correct slide is uploaded into the hub so that we can go through it. And I believe that there'll still be opportunities during the African Cafe and other sessions. But thank you for sharing that. It's time. We have less than 8 minutes to have questions and answers. I'll invite the panelists to just join us up here, and someone to help us with the roving microphone. The online team also, you're invited to share your questions. So Dr. Shafiq and Dr. Himen, Dr. Gugu, please join us up here on the hot seat. Is it very hot? I will need some roving mic. So fast, come fast serve. And keep it short. One for now, one question a person. So where are we? Please lift your hand so that I can see you. Okay, there.
Hello, good morning. My name is Dr. Alice Ketiadi. I'm the Chief of Fighting Against HIV in the Ministry of Public Health in Cameroon. So my question is, at the end of the presentation of South Africa, we realized that we have 1 million on people who were tested positive and who are not on mandatory PrEP is 1.1 million. And the strategies have been presented to us. So my question is to know if the country have implemented those strategies, what can really explain why the coverage gap is 1 million? Thank you.
Great, thank you. We'll take a few more questions, then we can answer. Go ahead.
Thank you.
All right.
My question is to the doctor from Nigeria. In Kenya, we are equally right now implementing the integration, but you said you started from bottom going up. I would like to know how this bottom going up is all about. Thank you.
So,
thank you.
I'm here.
Where?
Here.
Okay. Let's take there, then you next. Sorry.
Thank you very much and good morning. Thank you so much for the great presentations. So I am Peggy Kuchocha from Zimbabwe. So I'm particularly interested in testing of babies for early infant diagnosis. There is the presentation that was done by Anna, the first presentation that was done. It was talking about testing of children below 18 months, regardless of them being exposed to HIV. Maybe I would want to know more about it, and if you do have some data which is actually supporting that. Thank you.
Great, thank you. I know Anna is listening on the other side and she'll be able to respond to that. The tech team will help me. So we have John here, then next.
So greetings. My name is John Zakaria from Nigeria. My question goes to my Nigerian speaker. So I saw social protection, but I've not been seeing national team doing what we call capturing young people in social protection in Nigeria, which I know we have high inflation in Nigeria, and the government are capturing people in palliative, which since the capturing of palliative, they are using criteria of people with disability, minority groups, but young people living with HIV are not capturing the criteria. So I want to appeal you going back to Nigeria. You can help us to talk to your national team so that they can help us to capture young people living with HIV in Nigeria in part of the palliative. And I know in the next 2 months again, they are going to distribute palliative in Nigeria. And I guess it's going to be more important so that young people can not be using pockets to be spending a lot of, because of the high inflation, that to buy food again in Nigeria is a hard thing. Thank you.
Great, thank you. I'll just take 2 more, and because of time, so there's a hand there. I know, yeah, let's go there first. Go ahead.
Muito obrigada pela oportunidade. Nós temos notado em Moçambique uma tendência a crescer. Nós temos dificuldade em fazer diagnóstico, alcançar as metas de diagnóstico em crianças. E notei ali que alguns países têm sido bem-sucedidos ou estão melhores do que Moçambique na questão da diminuição, redução da taxa de transmissão vertical. Então, não sei como é que nós estamos em relação à redução da taxa de transmissão vertical em Moçambique, mas as metas para diagnóstico em crianças têm uma tendência a aumentar. Tendo que nós estamos a ter uma diminuição da taxa de transmissão vertical, como que nós podemos alcançar estas crianças? Será que nós estamos a ter a diminuição do diagnóstico, a dificuldade do diagnóstico, se deve à redução da vertical? É tudo.
Yeah, thank you. One more there, then I think we can answer. Sorry about that. Yep, go ahead. Yes. Oh, microphone, could someone help with the mic?
Hello. Yeah, my name is Ibrahim. I am a community adolescent treatment supporter in Tanzania. I just want to learn from South Africa what kind of criteria or procedure you have when you provide PrEP for pregnant mother. Thank you.
Great. So let's take those questions because of time. And I think without any particular order, let's give the mic to the panelists, please. Go ahead, Dr.
All right. Thank you. So to my Kenyan colleague that asked the integration implementation in Nigeria, the bottom-top approach, we discovered that most times as policymakers, we do policy from the national and then we just push it down to the subnational. It's not supposed to be like that. This Global Alliance implementation, what we did in Nigeria, we started from the subnational because they are the owners of the program, for them to come up with plans that speaks to their data, that is state specific. Because Nigeria is large, we have 36 plus 1 states. And in a state, you have like 17 million people, 18 million people. So we cannot at the national level sit and start planning for them. So that's what I meant by the bottom-top approach. So we guide them, we give them the guidelines, we assist them, but they make use of their state-specific data that differs from one state to the other. So no two states in Nigeria have the same data indicators because they are different in their topology, the LGA, the HIV burdens differ. So they are expected to make up plans that will suit or speak to their data. And then at the national, we just collate all the plans and see how we can coordinate. On integration of HIV services, like I said, is the way to go, honestly, if you want to attain sustainability. Nigeria have started the process. We have a lot of states, even in this hall, we have colleagues from Rivers, we have colleagues from Taraba State. They've started integration. They're integrating HIV services into the main service. We don't want HIV service to be set aside or to be a parallel program, because if you operate like that, it becomes difficult to sustain it when the time comes. My colleague from Nigeria, yes, including young people to be part of palliative is noted. I'll take it back. And then the other lady, I didn't quite hear what you were trying to say, but if you were asking of effective strategies for case finding, for us, there are a whole lot of strategies to find children. But from my presentation, I said for now, we are focusing on testing children of PLHIV. We have 1.56 of them. How many of them have children? How many of those children have been tested for HIV? Those tested, how many positive? Those positive, how many have we linked to care? How many of them are virally suppressed? We believe that if we explore that option, our coverage that is currently at 29% will definitely improve. Thank you.
Thank you very much. Dr. Shafik, you have any question?
I just maybe had a quick response to our colleague from Mozambique asking about how to improve coverage. I think Dr. Amen has covered it very nicely, but there are many strategies. UNICEF and partners put out a recent document called Case Finding in Children
beyond early infant diagnosis that we can provide you access to. It's publicly available, and it lists out some of the strategic approaches for you to reflect on. I want to remind us that we've always said EID, EID, EID is the answer to our solutions, and it's very important, but it's not sufficient, not in the current landscape. In many countries, South Africa is a fantastic example, Zimbabwe is a great example, Kenya is improving, Tanzania has high coverage, even in Mozambique. You have something like 70% coverage, according to the UNAIDS data, of early infant diagnosis among HIV-exposed infants. But remember that as you get lower and lower rates of vertical transmission, in South Africa now the rate is down to 2%, what that means practically is that for every 100 babies you test with EID, only 2 of them will actually test positive. So I think we have to strategically realize that there are other approaches that we need as well as EID. And one of them, which is very effective, is the case finding approach that Dr. Ayman mentioned. When you, no matter the prevalence in your country, if the group that you are targeting are adults living with HIV, you will find a high prevalence of HIV among their children. So even if your national prevalence is low, like it is in Nigeria or in Cameroon or in Cote d'Ivoire, even if your national prevalence is high, like in Zimbabwe or here in South Africa, the strategy of testing the children of adults living with HIV is always going to give you a high yield. And those adults are already on treatment. They are many times already coming to clinics. They understand the benefit and value of treatment. So it's a bit of a no-brainer that we should be testing those kids in order to identify undiagnosed kids in the community. Yeah. And let me hand over to Gugu to answer the questions about South Africa.
All right, thank you. And as you answered that, we have an additional question for South Africa from the online participants. And the question from Mary Owino is that, great presentation, a quick one for South Africa. What was the greatest challenge in rolling out PrEP, especially for the adolescent girls, young women, and how is the uptake at facility and community level? So you can include that in your response. Thank you.
Thank you very much. I think for South Africa, there's also another question that I will need you, Kulani, to, because I don't want to misquote the guidelines on the criteria for PrEP for the pregnant women. All right. There's a question that if then we do all these strategies that I've presented, why then the gap of 1.1 million? I just want to remind the House that South Africa is sitting with the largest burden of HIV across the world. I think we are the largest. And we have a largest ART coverage. So the strategies that I've presented that we have employed as a country has really assisted us to put more people on treatment. The 5.8 that I've presented that being on treatment was due to those strategies. However, we have realized that the 1.1 is disengaged on treatment. And the strategy, the main one that I've presented in terms of us setting aside the 100 facilities and identifying the highest burden facilities and putting more efforts in those facilities to ensure that we have an impact is the most assisted us to get more people that have disengaged on treatment. In 1 year, after we've set aside those facilities, we've managed to bring back to care and link back to care more than 300 clients that have disengaged on treatment. So in 2025 December, and
we are accelerating, as I've indicated that we've got 5, we are accelerating. So as we are doing that, we are mindful that 2025 is the year of us reporting on the 95 strategy. So we are actually pushing and ensuring that we meet those targets. We are not, it's a work in progress. We are not standing and saying, if then we review the strategy, if then we find that things are not moving as we are accelerating, we then go back to the drawing board and ensure that those strategies are reviewed. So we are saying we are progressing from what we are seeing, taking into consideration that we are sitting with the largest number of people that are living with HIV. Yeah. I would give Kulani to tackle the PrEP questions.
Yeah, just briefly because of time. Yeah, thank you.
Okay, good morning, colleagues. So for PrEP in South Africa, we use 2 or 3 criteria. The first thing, if all the pregnant women they test HIV negative, then we check if they are high risk or low risk, assessing if they are low risk and they're willing to take PrEP, we give them. If they are high risk also, we give them. So it's high risk and willingness to take PrEP. So we give information, we counsel about all the benefits and the risk. If they decide, even if they are low risk, they decide they are willing to take PrEP, we give them. And if they are high risk, also willing to take PrEP, we offer them. Thank you.
All right, great. Thank you.
On the challenges mainly that we have faced, especially at the community level, we have seen an uptake. It's coming all right, it's good, but we coupled to that, we are seeing a lot of STIs coming together with the PrEP. And when we engage at the community level, we find that especially men, they are starting to be naughty by women taking PrEP or anyone taking PrEP. They must not use the condoms. So we are trying to push the combined prevention strategies at a level of ensuring that as people are taking PrEP, but they must also use condoms coupled to that. So that is the main challenge that we are seeing. There is so much increase of STIs, especially that are coming up in our facilities now. Thank you.
All right, great. Thank you. I don't know if Anne is online, maybe to give us a parting shot. Is Anna online?
I am.
Okay.
Thank you. I hope you can hear me.
Yes, we can.
Okay, just to confirm, I think the question was from Zimbabwe, and largely my colleague Shafiq has already responded to the question on case finding that's indeed been quoted throughout our publications in the last couple of years. And South Africa is one of the examples that we provide. South Africa has implemented jointly together with PEPFAR programs, the policy to enhance HIV testing for infants and older children that's been missed by early infant diagnosis. And we would recommend implementing this kind of strategy in high prevalence settings, because we do see, and our data suggests that many cases were missed at early infant diagnosis. So the policy in South Africa suggests HIV testing at 18 months of all children, despite HIV exposure. This is also a part of the broader strategy that is now pushed by WHO and partners, and we will be looking at these numbers a little bit closely as the policy is being rolled out. But also just to mention that there is also another effort of pushing community engagement, and the programs that are related to this policy include community awareness campaigns to encourage parents to have their child tested, and to just basically at any entry point during immunization or a maternal health entry point. And we do believe that this testing strategies work in high prevalence settings. Thanks. I hope this responds to the question. And we're happy to also follow up with the policies and sharing some policies that also Shafiq has mentioned on case finding in infants and older children.
Wow, great, thank you. Unfortunately, we cannot take additional questions now, but let us interact. The team is here. Let's reach out, and any questions that are posted online, we will attempt to respond to them. But thank you very much, our panelists, and please let's give a round of applause to thank you for giving us the global view and giving us the country experiences, and we look forward to implementing as much as we can at facility level. So we are 10 minutes late, and so our next sessions will start at 11:10, but we need to catch up so that, thank you, Pakamani. I will need to catch up so that we are back on time. Remember that in the African Cafe, those who require French and Portuguese translation, please stay in this Lakeview room because the setting for translation is just here. For the rest of the team, as you go to the various rooms for the African Cafe, please make sure that you keep time. And if the room is full to capacity, you'll have to come here. So that means you need to take note of the time. Otherwise, thank you very much. And it was a pleasure serving you in the first session. Thank you.